Hi, my name is Dr. Christopher Parks. I'm an interventional pulmonologist in the Atlanta area. I treat a variety of pulmonary patients with both malignant and non-malignant conditions and patients with both early and late stage lung cancer. One of the modalities that's available to us for treatment is photophorin and photodynamic therapy. We routinely use photodynamic therapy in conjunction with chemotherapy, and it can be used in sequence with radiation therapy. The case I'd like to present today is of a 63-year-old gentleman who had been previously diagnosed with stage 3A adenocarcinoma of the lung at another facility. He had received concurrent chemo and radiation therapy and was not felt to be a good candidate for surgical resection. He was followed with routine CAT scans and had stable disease for several years. Unfortunately, eventually, he was noted to have multiple positive lymph nodes on his CAT scan, which was followed by a PET scan, which showed activity in several of these lymph nodes. It was at this time that he presented to our facility for additional diagnostic workup and treatment evaluation. The initial diagnostic evaluation was a bronchoscopy with endobronchial ultrasound, and biopsies of the lymph nodes were obtained showing recurrent adenocarcinoma of the lung. Of note, at the time of bronchoscopy, extensive endobronchial disease was seen, which was not appreciated on either the CAT scan or the PET scan. There was nearly occlusive disease of the left mainstem bronchus and extensive disease in the right mainstem bronchus. At this time, we presented him to our multidisciplinary tumor board, and a recommendation was made to proceed with chemotherapy as well as photodynamic therapy. He was injected with the photophorin and 48 hours later brought back for his first activation. He was activated in both the left and right mainstem bronchi with 200 joules worth of energy. 48 hours later, he was brought back for his second activation and his first clean out. And at this time, he was noticed to have an extensive inflammatory reaction, particularly in the left mainstem bronchus. This was cleaned with both cryotherapy as well as forceps, and we were able to achieve good airway patency. He was reactivated with 200 joules. He was brought back at day number 7 for a routine clean-out bronchoscopy, and at that time was noted to have, again, extensive inflammatory reaction, which was cleaned with both cryotherapy as well as forceps. We were able to achieve good airway patency, but due to the extensive nature of the inflammation, it was felt safest to continue with surveillance bronchoscopy on a weekly basis to allow us to continue to remove the necrotic debris. He eventually received 4 bronchoscopies with decreasing amounts of inflammation, and by bronchoscopy number 4, it was felt to be safe to wait until the routine follow-up bronchoscopy. This was done on approximately month 6, and on this bronchoscopy he was found to have no evidence of disease in the airway, with complete resolution of both the inflammatory as well as the malignant portions of the disease. Initially, we were concerned with the depth of the lesion, and at approximately 0.5 to 1 centimeters, whether photodynamic therapy would be able to be effective at this depth, and this patient had an excellent response. This demonstrates that there's both a prolonged inflammatory response in this patient's case, almost 6 weeks to the photodynamic therapy, as well as the ability to achieve greater depths than we had previously used this treatment modality for. Necrosis was seen up to 3 months after the initial activation with photodynamic therapy, indicating that there was continued to be inflammation in this area. This likely indicates an continued activation of the immune system with a response to the malignancy.
Please see full prescribing information for Photofrin, Porphyrin sodium for injection at www.photofrin.com. For more information about Photofrin, Porphyrin sodium for injection, or if there are any questions regarding the information provided, visit www.photofrin.com or please contact the Medical Information Department at 1-866-248-2039. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Photofrin, Porphyrin sodium for injection, and Optiguide are registered trademarks of Concordia Laboratories Incorporated. Pinnacle Biologics and the logo of Pinnacle Biologics are trademarks of Pinnacle Biologics Incorporated. Photofrin, Porphyrin sodium for injection, is distributed in the United States by Pinnacle Biologics Incorporated, Bannockburn, Illinois 60015. Photofrin, Porphyrin sodium for injection, should not be used in patients with porphyria, existing tracheoesophageal or bronchoesophageal fistula, tumors eroding into a major blood vessel. Emergency treatment of patients with severe acute respiratory distress caused by an obstructing endobronchial lesion, because 40 to 50 hours are required between injection of Photofrin, Porphyrin sodium for injection, and laser light treatment, and esophageal or gastric varices or esophageal ulcers greater than 1 centimeter in diameter. Important warnings and precautions using Photofrin, Porphyrin sodium for injection include gastroesophageal fistula and perforation. Do not initiate Photofrin, Porphyrin sodium for injection with photodynamic therapy, PDT, in patients with esophageal tumors eroding into the trachea or bronchial tree or bronchial wall. Pulmonary and gastroesophageal hemorrhage. Assess patients for tumors eroding into a pulmonary blood vessel and esophageal varices. Do not administer light directly to an area with esophageal varices. High-grade dysplasia, HGD, in Barrett's esophagus, BE. After treatment of HGD in BE, conduct endoscopic biopsy surveillance every 3 months until 4 consecutive negative evaluations for HGD have been recorded. Photosensitivity and ocular photosensitivity. Observe precautions to avoid exposure of skin and eyes to direct sunlight or bright indoor light for at least 30 days. Instruct patients when outdoors to wear dark sunglasses which have an average light transmittance of less than 4% for at least 30 days and until ocular sensitivity resolves. Use before or after radiotherapy. Allow 2 to 4 weeks between PDT and subsequent radiotherapy. Chest pain. Substernal chest pain can occur. Airway obstruction and respiratory distress. Administer with caution to patients with tumors in locations where treatment-induced inflammation can obstruct the main airway. Monitor patients closely between the laser light therapy and the mandatory debridement bronchoscopy for any evidence of respiratory distress. Esophageal strictures. Esophageal strictures can occur. Hepatic and renal impairment. Patients with hepatic or renal impairment may need longer precautionary measures for photosensitivity. Thromboembolism. Thromboembolic events can occur. Embryo-fetal toxicity. May cause embryo-fetal toxicity. Advise females of reproductive potential, of the potential risk to a fetus, and to use effective contraception. Most common adverse reactions reported during clinical trials, greater than 10% of patients, are esophageal cancer, anemia, pleural effusion, pyrexia, constipation, nausea, chest pain, pain, abdominal pain, dyspnea, photosensitivity reaction, pneumonia, vomiting, insomnia, back pain, pharyngitis. Obstructing endobronchial cancer, dyspnea, photosensitivity reaction, hemoptysis, pyrexia, cough, pneumonia. Superficial endobronchial tumors, exudate, photosensitivity reaction, bronchial obstruction, edema, bronchostenosis. High-grade dysplasia in Barrett's esophagus, photosensitivity reaction, esophageal stenosis, vomiting, chest pain, nausea, pyrexia, constipation, dysphagia, abdominal pain, pleural effusion, dehydration. Other photosensitizing agents may increase the risk of photosensitivity reaction. Because of the potential for serious adverse reactions in the breastfed infant, advise patients that breastfeeding is not recommended during treatment with Photofrin, porphyrin sodium for injection, and for 5 months after the last dose.